thank you for inviting Dean and I to speak with you today. I also want to acknowledge that besides the Okaki Health Intelligence, I also work on another initiative called Diabetes Wellness Initiative with Kataskinaw Tribal Council and Alberta Health Services. What we were asked to speak on today was, you better control that, how to engage First Nations communities. So in my experience working with First Nations communities, what I've found is that there needs to be a commitment to develop a relationship that is authentic. So what does it mean? It means to move past that work-in, that research relationship that we're used to coming into the communities with, and to build a relationship that is based on trust, respect, and honesty. So how do we start to build this authentic relationship? And this is something I recently learned with my other initiative I work with, is we need to stop talking and start listening to the communities. We need to listen to what the community considers important to them instead of assuming we know what the community needs. As you engage the community to hear what is important to them, it's also to prepare yourself as researchers, healthcare providers, scientists, that you're going to hear the good stories, but you're also going to hear the really bad stories to acknowledge that. For example, with one of our communities we worked with in Radar, we had a health director make this comment to us when we initially engaged them. And they came in, so what she said is, researchers came in, they did their thing, they would leave, and then we're no better off than when they initially came in. And I think that goes back to the helicopter research. So reminding us we need to work on our listening capacity and prioritize the community's needs first when we approach them. The other thing we want to acknowledge is the inherent rights of First Nations. So recognizing that there are treaties involved when you work with First Nations, and to understand what do they mean? What do they mean to the community, and how are you going to respect that? And to also acknowledge that there is diverse culture and language with each community you engaged. So the goal of engagement is, when you're committed to address the priorities and the needs of the communities, you need to ensure that you're listening to the community. And if you are listening and that you heard the community, the health services or the social services that you're going to provide is what the community asks for. Also, if you follow this process, you're going to find that communities are more engaged, and also they're going to be more invested in the health or social outcomes. Next slide. So identifying diabetes in First Nations communities. So speaking from our Radar experience, what we found is that it's mainly patient-driven, meaning that it requires the patient to present to the health center or the healthcare system. So patients often present to health center because they're experiencing signs and symptoms of diabetes, or they are referred to the health center, the healthcare system from a physician, and they're also accessing care because they're going to attend a health event, screening event, or a diabetes walk. So, so what we found is that there is no proactive approach from the communities in identifying their population or trying to identify high-risk patients in their community. And this is a challenge for anyone coming in to provide screening, as there is no systematic approach to screen for diabetes and find patients. We often find that patients are, sorry, I lost my speaker notes here. So we see patients less likely to interact with the healthcare center or the system because of the historical trauma that the patient may have encountered when they were attending the healthcare system and also the health center. We also find that patients are less likely to access care when, due to delay, they receive care in a delayed manner. Also to take into account that community health workers within these communities are at capacity, so they're unable to take on that screening role. In one of the communities we work in, we have a nurse who wears 3 hats. So other than being a diabetes nurse, she's also a home care nurse, she's also a foot care nurse. So she's at capacity and unable to take on that screening role that's also needed within the communities. And also some communities do not have the resource to take on that screening initiative, and to acknowledge that. Geographic access. If you've ever been to some of the communities in Alberta, you would see that a lot of the patients have difficulty accessing care just based on where they live in the community. In one of the northern communities I worked in, I had a patient that used to come see me, and it would take him 45 minutes to come to his appointment, and that was on a good day when the roads were accessible. He would have to travel up to 2 hours to make his appointment. So recognizing those barriers of what our patients have to come to when they access care. Oh, this map. Dean may need to jump in if I don't get this right. So when you're talking about screening for diabetes in the community, it's important to define what are you screening for. Are you screening a community population during a particular time? Or are you trying to capture the complete diabetes population for that community? For this community here, you can see that the community members access care across Canada. The healthcare is being billed back to the community, but if you're going in to develop a screening campaign, you're probably only going to capture a small snapshot of the people at risk of having diabetes, if you're only going to look at that particular community. Did I get that right?
Yep.
Perfect. So what do we need to do when we're thinking about screening and identifying diabetes in the community? Well, we need to be a bit more proactive. So what does that mean? It's investing in an electronic health record to help identify and track patients with diabetes. We also need to start screening individuals who present at the health center with risk factors. They may not have diabetes, but we want to screen those when they do access the health center. Also, we want to take every opportunity to screen and identify the high-risk population, whether it's through identifying them at flu clinics, social gatherings, or any diabetes day clinics that they have. And also, the last thing I want to talk about is when you are going to implement a screening program to consider that community's language and their culture when you're implementing a program. And to also, from what I've heard today, to consult with the community and ask them, if we were to host a screening program in your community, what does this look like, and what are the steps so that we have a program that's appropriate for your community? Thank you.
Maybe this will work. Nope. Next slide, please. Yeah. So one of the foundations to any types of screening program, I think, is really information systems. One of the things that we've noticed when we go into these communities is that diabetes management, diabetes screening seems to fall on one, maybe two individuals within the community. And these individuals are often still using a number of different non-electronic means of trying to track the population. And so when I first started with the communities, the one word I kept hearing over and over were ticklers. And I was like, what is a tickler? And it took me many months to figure out what they actually mean. And it's really just a list that they have been keeping over the years, tucked away in their little desks, of all the patients who they know either have diabetes or at high risk for diabetes. And unfortunately, what's happened in a couple of communities is that some of these nurses and healthcare workers have retired, and they've retired with their list. And so the community is back at square one because it really wasn't written down anywhere else. And so when you look at the Canadian Diabetes Guidelines, they really stress that information systems become a key part of trying to track your population with diabetes in the communities. And they talk about the 5 R's. And for those of you who are not familiar with the 5 Rs, and I can never remember them, it's trying to recognize those patients in your community who are going to be at high risk and try to implement those screening programs. Register those individuals in an easily accessible information system so that as people come and leave the communities, that information still stays with the communities and easily accessible. Resource is probably one of the biggest ones. You have to make sure that you have enough resources in terms of personnel to try to look after these individuals. One of the biggest things that we found in working with these communities is they're at capacity. And so, you know, when we talked about screening with some of these communities, they weren't interested in screening anymore because they already had more people with diabetes than they knew what to do with. And so they really didn't want to add more to the workload that they weren't keeping up with already because they were under-resourced. The other one is relay. You need to have good relay of information within the community itself. In many of these health centers, you have community and public health, you have home care, you may have some physicians that are working within the community, but then you also have in Alberta, you know, the external healthcare workers who are often providing a lot of care for these clients. And as a result, there's not a lot of information flowing within the communities and outside of the communities. And so there's a lot of individuals who are really in the dark in terms of what and how to manage these patients. And the last one is really the recall system. So once you identify the individuals so that you can bring them back to the health center, easily identify them so that you can try to manage them and try to reach some of the targets that you've set up for that individual over time. But in order to do that, you know, you really need a lot of infrastructure to try to do this. And so for us, going into many of these communities, what we found is that they didn't even have the basics of NetCare within the communities. So NetCare is Alberta's provincial system where all laboratory, x-rays, those types of information all end up so that anyone who has access can see that information. So no matter where it's been done in the province, it shows up in a central repository. The first step in most of these communities was trying to get them on NetCare. And that proved difficult in some communities, not because of the community, but simply because of Health Canada. Alberta has very strict regulations of what the computers have to have on them in order to have NetCare. Well, Health Canada wasn't willing to provide that computer. And so in some communities, we actually had directors with 2 computers on their desk. One that we provided to them that met the security that Alberta Health needed, and then their Health Canada type of programs and that on their other computer. So again, even within the simple thing of trying to get access to information, it's very difficult within some of these communities. And there's often, you know, issues of trust and privacy. Who's going to see the information? We spent a lot of time talking to the communities about who has access and that they're in control of their own data is a big one. And so they have to decide who within their own communities do they want to have access to this information. But the information then has to go beyond just simply collecting that information. You really need to have a very robust, not only electronic medical record system or EMR system where you can track this information, but also on the backside, you need to be able to have some population type analytics. You need to be able to pull out of those EMRs, who are my high-risk patients, so I can maybe focus my screening programs at those individuals. As we said, resources are scarce in some of these communities. They don't have a lot of personnel to run these programs, and so trying to direct and target them to the high-risk individuals will be better bang for the buck in the long run than what's currently being done. We also be able to track some of these individuals over time. So once you've identified them as either a high-risk individual, you need to be able to track that you have actually screened them. And so next year when the screening programs come around, that individual may not need to be screened based on the risk set, or that they need to be rescreened because they are a very high-risk individual. And then you need to be able to share that information seamlessly. So a lot of screening is actually happening outside of the communities. You know, physicians' offices that are screening, the nurses they see are screening them, but it's not coming back to the communities. And as a result, the communities aren't aware that some of that screening has actually happened. And then at the end of the day, as John kind of alluded to, you have to kind of put in some realistic, measurable goals that you want to try to achieve for the community as a whole, as well as for the individuals. And that can be difficult to do when you're not really sure what the complete information picture is for an individual with respect to their health system. Some of the communities that we initially started with were still on paper-based type systems, but the paper-based systems were actually two different systems. They'd have a system for home care, and then they'd have another system for the community health, public health side. And a lot of times the information didn't even make it across within the community, let alone outside the community. And then you had the physicians, the nurses, the pharmacists working outside the community, never sharing information back to those individuals who was actually looking after the individuals. So there was lots of simple things that had to be done to try to get things going. And so with all that in mind, this was a project that came about with one of our communities. We had shown them the diabetes map that Carrie had shown you, and they were surprised at the number of people they had with diabetes, but then they were also surprised of our care is being accessed all across the country. And so we came up with the what we call is the RADAR program. Stands for Reorganizing the Approach to Diabetes through the Application of Registries. And in the research world, you always have to have a good logo. And so we spent a lot of time with the communities trying to come up with a logo for the project. And one of the elders really spent some time with us and really came up with a great logo. So the letters represent the idea of information traveling from an input to a transformational outcome. The beginning of the R represents the input of information into the registry, and at the end of the acronym comes the eagle in flight, symbolizing healing and illumination. And the icon of the radar is used as both a data reference, however, it also symbolizes the medicine wheel, which is important in Aboriginal healing. And so it was a great symbol for the whole project. So what was radar? Well, radar is really two different pieces. One of it is the information side, and then the other side is really the care side. I know for a fact that I can improve outcomes in patients with diabetes in these communities if I can take Carrie or Denise or any of our other care coordinators, replicate them, and have them planted and working with those individuals. But it's just not feasible. There's not enough money for these communities to hire another nurse just specifically for diabetes. As Carrie said, many of these nurses are wearing 2, 3 different hats. Some communities don't even have nurses. They have other community health workers. And so we had to figure out a way, how can we improve the health of a population, but do it in an economical and sustainable point of view so that, as Carrie said, when the research side leaves, that there's still going to be a lasting impact for these communities. And so we came up with a two-part system. The first part was an integrated electronic patient registry and medical record system, and I'll show you a little bit of what that looks like later. It's called the CARE program. It's already in many communities within the province already. And it's not a standalone system. This system, it was really built two aspects. One was an electronic medical record, but on the back side of it was also an analytic engine, what would allow the communities to quickly find patients within their populations who have high blood pressure, who have poor kidney function, who have other high-risk factors for diabetes, so that they could target in on those individuals. And it really allows those 5 R's of the Canadian Diabetes Association to really play out, so they can identify, track, monitor, and try to synthesize some of that information into a very succinct format. So there's a lot of care plans built into there. There's forms that can be generated out of it, so that allows them to quickly share information not only within the community but outside the community. And again, it provides that analysis of population data to see how they're doing as a whole as they move forward. But one part what came quickly very evident to us when talking to the communities is that they just didn't have the capacity to really do some of this stuff. Their nurses were already working 110%, and they couldn't add any more information on top of that. And there was also some evidence gaps. Many of the communities were very, very forward, saying they really didn't know how to manage diabetes well. They didn't have the expertise within their communities to really make the impacts that they wanted to make. And so we decided to come up with the care coordinator role. The care coordinator is somebody what we located centrally. So in this case, they're located in Edmonton, but it doesn't really matter where they're located. Their job is really to work electronically through the care program to interact through case conferencing, Skype, those types of mediums with the frontline health workers. And so the care coordinators don't have any direct interaction with clients per se. All their interaction is with the frontline health workers to try to support them to identify the patients that really need the following up and to work that way. And again, if you can imagine, this is a fairly simple model to scale. Each care coordinator tends to work about a day a week with a community, and so within a couple care coordinators you can cover off 10, 15 communities quite easily, and so we thought it was probably more economical for these communities to try to do this type of a model than it would be to support and pay for a nurse to come in to try to work with the communities on a full-time basis. So we currently have 6 different First Nations communities that we're working with. The 7th community is coming online very shortly. We've also had a number of different funding bodies that have helped out and really moved this forward, which we're very grateful for. And so far, I think it's going quite well. The communities seem to be thinking the program is beneficial, and so we're going to move forward for another couple of years, and then we're going to have a complete evaluation of the program. One thing that we do not want to do is put in a program in place that's really not changing outcomes. There's a lot of quality improvement programs that are being put into place all around the country in both First Nation and non-First Nations communities that really don't have any evaluation plan at the end of them. And so you spend a lot of money, but at the end of the day, you really don't know whether or not it works. And so the whole radar model was set up really in 2 pieces. On one side, we had Okaki Health, where Carrie and Denise and them worked. They're involved with all the clinical side of things, and that's all they do. My role is really at the end of all this. So in 2021, when the program comes to an end, I'll look at the data and say, did we make an impact? Were we able to change the number of people in terms of some of the clinical targets? Do the communities find it beneficial in terms of some of the quality indicators that we have put in place? And if the answer is no, then this model doesn't work, and you shouldn't be putting money into it from a community point of view. And so we really wanted to make sure that we had a very robust endpoint at the end. So what does the care program look like? So I'll just give you a couple of brief examples. On the very surface, it's a web-based portal. So the communities access the care program. The information is kept in the cloud. It's all very secured, and it's not my area of expertise, but it meets all the requirements that you could ever want for secure data. But they can access it through the web, and all their client information is in there. Next slide. So on the surface, it's an EMR, so you can track all their different chronic diseases, all their visit dates, all their notes that you normally would have into any electronic medical records included. And so within that, it looks very similar to every other TELUS Wolf or any of those other ones which you might use. One thing that is different with it, though, is it has been built specifically for the First Nations communities. There are certain requirements that they have to do in terms of reporting to Health Canada to get their money for home care and other things, and so that has been built into it. The other thing that's very different is that as the community tells us what works and what doesn't work, we update the features very quickly. So every 3 to 4 months, the build team tries to implement what the frontline workers would really like to see in terms of trying to use the information. This is just a list of their of a sample fictitious patient in terms of what their medications. So again, it tracks all their medications, all their labs, all those types of things. The other thing we do for the communities is that one of the things that we found is that if we gave the communities Netcare, what has all the lab data on these patients, they still weren't using it. The reality is they did not have enough time to look it up and put it into the electronic medical record. They were just too busy trying to look after the clients. And so on the back end, we also have medical individuals who actually go to Netcare, look up the information for the communities, and make sure that their EMRs are up to date. So all the information that's in Netcare is quickly put into the EMR system for the communities so that when they log in and look at a patient, they know that it's the most up-to-date information on that individual. In the future, the care program will actually be able to interact directly with Netcare and pull that information automatically, but they're still in the testing phase of some of that stuff with Alberta Health. Within it, we also have a very specific diabetes module, so we've worked with Alberta Health Services and other individuals to put in all the basic requirements that you'd want to see in terms of diabetes care. So this is an example of the foot assessment that the nurses or community health workers do, and so they can enter all that information directly into the care program so that the next person comes in, they know that the assessment has been done, what the results are, those types of things. Probably the biggest thing for the CARE program is that with the CARE coordinators, they can actually enter in all the tasks and outcomes that need to be done on each individual patient. So for instance, we're coming up on flu season, so they may have entered a task saying you got to get this person in for their flu shot. They may have another task that we haven't had an A1C on this person for over a year, and so we have to have a task to get this person back in to get their blood glucose checked, their eyes checked, whatever it happens to be. And so again, it's that reminder for the system that'll come up to try to track those individuals to see who's actually due for care, so that they can get them in and be a little more proactive in terms of trying to manage them, as opposed to trying to wait for the patient just to show up on their doorstep before they do some of these initiatives. So what do some of these patients look like? So this is a random subset of patients. This is not one particular community by any stretch of the imagination, but it is a pretty typical population of what you'd expect in Canada, I think, in terms of diabetes. Their average age was around 59, but we have individuals all the way down to 20, up to 90. We didn't include children in the program, that we kept them separate. And so if you're wondering why we're not seeing younger ones, it's because it was a protocol that was put in place. 63% are male, and as we'd expect, of the people we have data on, obesity was definitely a problem. So again, we only had data on about 33% of individuals where we had a height or weight put into the system. In terms of clinical outcomes, the communities are very good at measuring blood glucose and making sure it's actually entered into the electronic medical record. So we only have about 5% of the population that doesn't have, a reasonably up-to-date A1C value, which is excellent. On the other side of the coin, though, certain aspects such as systolic and diastolic blood pressure, you can see we're missing about 81%. Now that 81% doesn't mean it hasn't been measured, it just hasn't been entered into the EMR. And so when somebody goes in to look, it's just blank information. So I would suspect there's a lot more measurement happening on the patients, but it's just not making it into the records as we would like to see. In terms of their other labs, we know these are a little more accurate. About 20% are missing LDL, HDL, and about 20% are missing measures of kidney function. So overall, it's not too terrible. There's lots of measurement happening, and this is probably pretty typical of what you'd see in a community outside of the First Nation realm as well, where you have about 20% of individuals where we really don't know what's going on. Other aspects such as eye examinations are fairly high at around 60%. There's a lot of foot examinations done. So in a lot of the communities, the foot examination is also a gathering time where they'll come in and spend time in the community, and then they'll do the foot exams at the same time when they're doing crafts or other aspects of it. And then this was influenza vaccination again. We know it's much higher than that, but it's probably not making it into the medical record. They were using other ticklers and other methods to try to track that information. Back, this is about a year ago, I think, the data, maybe even 2 years ago, the care coordinators had done over 600 complete reviews of clients. So they had gone through all the clients. They had made 125 foot referrals, over 75 retinal referrals, and over 200 labs had been ordered on the individuals to try to fill in some of those gaps so we can see where the population is at. The one thing I can tell you is that the amount of information that is changing hands within the community and outside the community is actually very, very small when Radar first started. So we had a community that actually had a tele-ophthalmology unit within the First Nations community. 300 yards down the road was the physicians who were off of the First Nation land. They were seeing the same clients, so most of the clients were shared between the two groups. The physicians were sending all their clients about 3.5 hours to Edmonton to get retinal photography done. We had a meeting up there. It was the first time the health director had ever met the physicians and vice versa. And out of that conversation, they now realize that there's a tele-ophthalmology unit right within the community, and instead of going 3 hours, they go 300 feet across the street and get it done. And so that's the level at some of these communities are at in terms of the lack of communication. Other aspects would have changed a lot is now the physicians, whenever they change a medication, whenever they make other referrals, recommendations, they actually fax the community health center so that they're aware of what changes they're making on the clients. And so it's a much more open dialogue between the two groups in terms of trying to manage the patients. So even if we don't change some of maybe the hard clinical outcomes, RADAR has definitely improved the communication within many of these communities, and there's a lot more coordination, a lot more multidisciplinary care happening for the clients as they move forward. And that's about all I got to say. You got anything else to add, Carrie? Nope.
Thanks very much, Dean. And actually, the Accord group, I'd encourage everyone, if they're not aware of it, the ACHORD, the Alliance for Canadian Outcomes Research in Diabetes, does have a lot of significantly great resources in terms of a lot of work that has been done in trying to past work and looking at diabetes atlases and various other kind of things, trying to track surveillance where people are. We have time for a couple of questions if they wanted before we're going to take a bit of a break. Okay, just here.
My question is just how quickly it is to, I guess, access the, say, a particular client right in front of you that comes in, or a nurse calls you up and says, okay, I need this information now. How quickly is that able to be generated?
Usually if the communities have access to Netcare, so the nurse will have access, so she can access Netcare and enter it herself. But also, we, the care coordinators, we on a continual basis enter the lab work on a week, like for the communities. And on top of that, we have 2 medical data entry clerks that enter the data. So we would say within a couple of days, the information's getting in there. And the community is really great at communicating with the care coordinators to let us know, we have a new patient coming in, we need the meds updated, we need the labs updated. Can you case review this client before we ever speak to that client?
And we do have, that I think is one particular advance which Alberta has been the development of Netcare, in which all lab and prescriptions are available and online, and there is a major movement now to try and input and incorporate other primary care data to be readily available. But I think it would be an interesting and important initiative. This is just personally to the federal government people who are in the room, in terms of as one looks at Canadian Health Infoway, which has been in the past looking at often acute care data, but an area of primary care, an area of significant focus where one might look at virtual health care and where some targeted resources in health IT might have significant impact in Indigenous populations.